Okay, so we're going to continue on and look at a question regarding the contralateral Lassaix or the slump test. But first, I already listened to the first recording back, and sorry, it's probably a little boring and monotone. But that's what happened. I'm trying to keep my pace steady in case you are translating, and certainly to make it easier, but we'll pick it up. We'll use some more inflection here. So this question was regarding, if these particular tests provide an indication that there might be, a more positive outcome, and so it is along the lines of, say, a clinical prediction rule, or we don't call them rules anymore. We call them guidelines, because if a rule is broken and you don't completely follow the rule, it means that you're doing something wrong, and that's not necessarily the case. So first off, when we look at clinical prediction rules, here's of particular interest. So this was a clinical prediction rule. First off, even to look at how these are produced. They take a considerable amount of time, and they certainly take a considerable amount of subjects to accomplish, the specific guideline or some statistical criteria that we could use to go forth and say that, these group of things are good indicators. So here's two clinical prediction rules. So the first one is showing, and I just want to, bring the note to, no neurological involvement is a good prediction in this case that traction can be beneficial. And then we go to this next one. So this next one is again by Julie Fritz's group, who's done a lot of the CPR rules, and this one was originally done back in 2007. Actually, the work for that occurred much earlier than that, but this was a study that utilized these clinical prediction rules, and essentially the conclusion is that, specifically with this one, that if there is neurological symptoms such as the radiculopathy, then that enhances the prediction that traction is actually going to be beneficial. So even within our rule pattern, we find that it's not completely consistent, and there's actually opposing information. And what's also interesting is this group actually did a follow-up to this particular study and started publishing it in an abstract in 2015, and we actually funded this study, and they found the opposite. So they found that there was no benefit in this particular group with the ridiculous symptoms. But if you look at the comparison, so in the 2007 study, they were treating patients 4 times a week initially, and then went to 2 times a week for the last 2 weeks. And when we look at the comparison to the 2015 study, what a lot of people don't understand is the difference in the dose response. So they treated patients on average less than 1.5 times a week. And so it's not to say that the treatment approach is ineffective. It's simply ineffective if you're not using the appropriate dose response. In other words, you have to treat patients enough times per week to get the benefit. And that makes a lot of sense, especially from a passive modality standpoint. This is a great study by Rezka Allah and their group. And what was interesting is they used slump stretching and straight leg raise as a form of treatment in patients with herniation presentations and radiculopathy. So they measured pain, and they measured H reflex. So an H reflex is the Hoffman reflex response, looking at the excitability of a motor neuron pool. At the end, they didn't find any difference between the two assessments, and there wasn't a control group, so it wasn't a randomized clinical control trial. But again, what was interesting is they used one of these particular assessment tests as a means of actually addressing and determining the effectiveness of a particular approach. So we ask the question, why would you do something like that that's normally used to elicit a problem? And so when we look at the slump test, the other neurological tests associated with assessing really the position of the space-occupying lesion, such as a disc herniation, and why we use the straight leg raise and then the well leg raise, or the contralateral Lasaik's or contralateral straight leg raise, is to really help us to determine the position of the herniation or the space-occupying lesion. And I think what this tells us is that it may not be that important, and again, that the outcome approach really is what can we accomplish from the specific tests. And if we think about what these tests actually do, is they create stress to the neurological tissue, and it moves it and provides a form of mobility. So to the question of, do we think that those particular findings may be more beneficial in determining whether or not a spinal distraction approach may be beneficial, in my opinion, it's actually going to be yes. And what's interesting is when we look at the use of nerve flossing, neurological flossing, it creates mobility, and it creates mobility within the nerve tissue, so the spinal cord, the nerve roots, and the dura, and of course anything that's holding any of those particular tissues in place. And we can further look into some of the other studies on cadaveric specimens where patients had nonspecific low back pain. It's not identifiable on any sort of assessment tests, including imaging studies. And in cadaveric specimens following their passing, finding adhesions, so fibrosing that's holding and creating restriction to the mobility of these particular tissues. And I think that's potentially one of the explanations of why we're successful in treating some of these chronic conditions of nonspecific low back pain, because of this mobility piece. And to take it a step further, you could actually use spinal distraction to further enhance this neural flossing. And what you can do is you can add a straight leg raise or a chin tuck maneuver during the process of mobility when you're doing intermittent traction. The downside is you have to be there with the patient to assist them in that process, but it assists in the mobilization of that tissue, including the connective tissue. And I'm going to show you a case a little bit later of where this might be really beneficial, where there's certainly some limited mobility. Criteria for the loading scheme. This is an interesting topic, and I think what we really have available to us is we have some guidelines. I think the basic guideline is going to be the minimum, and the minimum is going to be established by understanding what your equipment can do and where it actually is going to be beneficial in initiating some of the mobility with regards to the patients. I'm not sure there's actually a maximum. I think there's one case where there is in fact a maximum, and we'll look at that in just a second. So I'm actually going to use the one of my tables, the TRT 600, as an example here. So I did some assessment in looking at this particular table, and where it actually starts to provide some motion. And the reason for this is when we look at the comparison between a table that has a split design to it versus a stationary table, and that also includes in the cervical pieces. So the cervical pieces that run on a sled, like the Saunders, can provide a very low friction, a very low coefficient friction, and even though we add mass to it vertically and we're pulling horizontally, we can actually minimize the effectiveness of body mass. So what that's done for us with today's technology and today's treatment is it's helped us to obviate body mass, so we don't have to use that 50%. So this is looking at a lateral view of the table, and this is just a hook that's actually connected to the split, and then you can see here there's a chain that's connected to the traction head. So as we start to add load, no load, and then we start to add progression. So this is setting the device to 10 pounds, so about 4.5 kilograms, and attaching it to the table and seeing when the table actually starts to separate. So the table, as we can see, actually starts to separate somewhere around 9 kilograms or 20 pounds, and that's with no load. So there's nobody on the table, and that's only the traction head attached to the split of the table itself. And then we see at 30 pounds it progresses, and then we see the same thing at 40 pounds. It also continues to progress. So in other words, the further that you increase the intensity, the more the separation in the table. Now keep in mind that's the table, not attached to a patient. There's no relationship to the degree of separation of the table and the actual separation of the patient, because the tables separate to a much greater extent than the separation of someone's spine. And then we can look at when the table is loaded. And what I mean by loaded is there's an additional weight sitting on top of the table of 109 kilograms. And that's actually me sitting on top of the table, and we go through the exact same process where there's zero load, and then we add approximately 4.5 kilograms or 10 pounds, and you can see that the table starts to separate. And if we do a comparison between the different loads of the table separation with the 109 kilogram load on top of the table and no load on top of the table actually separates to the same degree with the same amount of distraction force. In other words, no matter how much weight you put on that table, at least to a certain perspective, usually a patient, it doesn't require any more resistance by the traction head itself to actually separate that table. Well, what does that mean to us? Well, in today's low coefficient friction designs, it means a lot to us. So no longer do we calculate the application by the percentage of body mass. So this is an earlier study done by Ramos and Martin. So this is the VAX-D table, really the leader in, or founder in, the development of what a lot of people refer to as decompression. So just to note, when we look at 3 of their subjects, and so at measurement 1, there's no tension applied to the patient, but yet they all have different intradiscal pressures. So there's a cannula inside of the disc, and they're measuring the intradiscal pressure relative to the amount of distraction force. So if you look across, one of the things that you'll notice is there's no consistency. In other words, when we pull someone at 10 pounds, 20 pounds, 30 pounds, it's really different from one patient to the next. So we can't use the resistance to determine what is actually going on with the patient, at least from a discal pressure standpoint. But one of the things that we do know is we seem to level off with regards to disc pressure, and that leveling off is somewhere around 45 kilograms or 100 pounds. In other words, once we get to that 45 kilograms and you pull any harder, their disc pressure doesn't go any further down. It doesn't go any more negative. So if your idea was to create negative intradiscal pressure, once you go any further than that 45 kilograms, you're not going to get any more intradiscal pressure going negative. And that's an important concept if, in fact, that was your actual goal. And this is not a new concept either. So this concept has been developed for several decades, and even before the VAX-D, with many different tables. Actually, the predecessor to the DTS with O'Neill in the 70s and into the 80s, they've been measuring discal pressure, and basically one consistency we can say is the further that you pull, the harder that you pull with a higher intensity, there's this inverse relationship. In other words, the higher the intensity, the lower the disc pressure. So potentially what that translates into is the greater the degree of separation. But what we can't say is what exactly that degree of separation is, or the actual disc pressure. So To use a specific intensity to deliver and create a specific outcome is very difficult to accomplish other than when we start at those beginning stages. So there's been several studies, and here's Santos and Ribio looking at, the effect of certain percentages of body weight. And what's interesting is, even on the split table designs, what we tend to find is very, very low intensities start to create what we didn't know since the 1980s, starts to create that separation. And I use this paper a lot. This is by Sari, and I'll show this one again. But to look at the effect of what's happening goes well beyond just looking at the disc and what we can accomplish by separating vertebral structures. And the consistency is not in percent of body mass, but actually in the delivery of a very specific intensity that's being controlled during certain types of research. And then in another study using increments of 5 kilograms to show that basically when we start at the point where we see separation in vertebral structures, there's again a direct relationship between the increase in the intensity as well as the change in what's going on mechanically or the separation between these particular structures. And in fact, it actually separates at very, very low intensities in both the cervical and the lumbar spine, which is far less than what most people considered when using the 50% of body mass. Some great work done by Proulx and looking at the influence of separation neurologically, and that's actually been a lot of my interest is, what can we do neurologically and why does it happen, and especially if we can accomplish some things at very low intensities. And the reason for that is when we find people that have had a bout of low back pain, what they tend to experience is continued neurological deficits. Motor patterns are inappropriate, there's latency responses, and unless they've actually gone through some form of rehabilitation, it tends to always be there. And that's been also shown by the work of Stuart McGill when he was determining that, using criteria for patient population during research, someone who's 3 weeks or 3 months or 3 years, they're actually very different. So a lot of times we used to use 1 year being injury-free as a criteria when we should say 1 year injury-free, but also had been rehabilitated. Along with that is understanding that there is a certain degree of myoelectrical activity even in a patient who is a subject and asymptomatic, and that normal subjects potentially have an increase in muscle activity even before we start to retract them. And so again, that's been shown in both the cervical and the lumbar spine. So we're looking at the paper by Proulx. And what's interesting by this particular paper, and this has been crucial to me in developing the low end, the minimum, is the amount of distraction force that actually starts to separate the sacrum and L5 is only 25 newtons or 6.37 pounds, which is a really, really small amount of force to separate those particular structures. And that's done on a table that has a very low coefficient friction system to it. So when we take all this information and we kind of put it together, we know that there's a low end. So the low end is you got to know your table first. So you need to know at what point your table is actually pulling somewhere around 3 kilograms. At 3 kilograms, after removing the resistive forces such as your countertraction spring on your table and any mass associated with the table, that's where you start to see separation of the vertebral structures. So the benefit there is now I know the bottom limit. And the benefit of that is if I'm actually going to treat a patient where I'd like to apply tension to the tissue without large amounts of separation or movement in potentially injured tissue, is I know that I can start them off at a certain percentage of that resistance. And in this case, in my table, and that's, you have to know your table, it's at approximately 25 pounds, or about 12 kilograms, 11.5 kilograms. So my starting point for all of my acute patients is going to be that. And my starting point for anyone that is not acute is going to be slightly higher, knowing that my indication really for those patients is I want to start to see some separation or create some mobilization in the tissue. So we can't use the resistance as necessarily a criteria once we get beyond that starting point. From then on out, and I talk about this in a little bit, is any change in the resistance is actually going to be based on patient outcomes. So you have to measure something. What is going to change in the patient? Is it pain presentation, or is it mobility? So we never ask a patient if they can feel it, but it's more associated with a specific outcome. And I'll talk about progression in a couple of moments here, but there really isn't any maximum. So we know that the failure rate of the connective tissue, the muscles, ligaments, tendons, and discs in the spine is very, very high, and we cannot pull high enough to potentially create as much damage. In fact, with manual therapy and manipulation, we have a greater chance of creating such damage. So with distraction forces, they're relatively low in comparison to the failure rate of the connective tissue in the lumbar and the cervical spine. So at least on the DTS table, I find that my starting point is usually about 15 kilograms, between 11 and 15 kilograms. It's not about body weight, and that's going to be in the lumbar spine, and then it's approximately 4 kilograms in the cervical spine, again making sure that you have the appropriate settings for the patient position.